This is a general introduction to group psychotherapy using an evidence-based group treatment website or other ways of really trying to understand the group website and also group treatment in general. So what I want to do is begin with just sort of a conceptual framework, a way of understanding the group treatment literature, which if you get into the evidence-based group treatment literature, appears in 300 plus journals, scientific articles on this. And we'll just hit at a high level that we have a number of groups that are leaderless. These could be self-help groups, 12-step groups, support groups, and by definition, there's no leader. In the empirical literature, these kind of groups often appear as control or comparison groups. There's also a very heavy use of psychoeducational groups. As you can see in the graph, these might be for psychiatric conditions like bipolar disorder, strong literature on psychoeducational groups being helpful, kind of in a medication management approach, disease management for bipolar, but also groups we see inside of medical systems, cancer groups, for instance. And then lastly, we have psychotherapy groups. There's going to be two types primarily. One is manualized groups. These are often more of the evidence-based groups that have 10 sessions, 15 sessions, 20 sessions. So they're time limited. And contrasted are more model or principle-based groups. And these are going to be guided by, and often they're more unstructured and often more in a timeless fashion. They might last 6, 12, in fact, many years. This is a way that Bernard Strauss and I have put together what might be going on in an evidence-based group therapist head. One is having a research treatment protocol, a guide, if you will. Now, back to the slide I just showed you, that could be a manual that's guiding treatment or a model that's principle-based. Practice guidelines. These are principles. They're kind of meta in format. The American Group Psychotherapy Association has, it's in its second edition of having practice guidelines for how to guide treatment. I'll give you an example of that in a minute. Using measures to know, maybe like help select patients into a group, know what's going on in the minds of the group members with respect to symptoms or how they're experiencing the group, the therapeutic relationships in the group. And then lastly, some multicultural competence. So as the group goes to different populations, we know that it's sensitive to the cultural implications of the members. If you try to explain what helps members in a group improve, Bernard Strauss and I put this model together a few decades ago, and they're the main sources that help us understand improvement in group. So structural factors are kind of like the bones, if you will, of a group. How many sessions is it? Am I using pre-group preparation? Am I explaining the work and the tasks of the group? All of the things that you would do across different types of groups would hit in the structural area. Patient considerations. A moment ago I talked about selecting patients. These could be selecting patients that are the most appropriate for group treatment, but also if you're running a disorder-specific group. What's the severity of a patient in a major depression group? What's the severity of their symptoms? Small group processes, we're going to have a module on that, but these are the therapeutic characteristics, the therapeutic properties of the group. Cohesion is one of the best predictors, for instance, of improvement in group, and that would be a small group process. I just talked about formal change theory. So this is a theoretical orientation that's guiding the group leader in his or her group. And that could be any of those characteristics: leaderless, psychoed, manual-based, or principle-based. And in the center, the leader, we've placed the leader in the center. The characteristics leader critical, but also she's really the center driving the group in all these other four sources. And then one of the things that's always a challenge, because many of us are trained as individual therapists, is helping patients really understand that group is an effective treatment. In Yalom and Lesch's last book, they talked about the triple E piece of group: effective, efficient, and equivalent. This slide focuses on equivalence. So it gets at improvement in group versus individual therapy. And this is a summary of two studies that appeared in 2016 that came out of our lab. One is a meta-analysis that had over 6,000 patients scattered across nearly 70 studies. And all of these were randomized clinical trials. One of the differences between these randomized clinical trials was the majority of them were the two conditions, individual versus group, were identical with respect to patients, dose, and the theoretical orientation or the formal change theory guiding treatment. There was a smaller number, right around 20 studies, where there were non-identical comparisons. So the individual had different patients or different dose than group. So we gathered both of these groups of studies, and when we looked at the differences, you can see, particularly in the identical comparisons, no difference in short or long-term improvement and follow-up, no differences in acceptance, no differences in dropout, remission, and improvement, which of course is the equivalence message that I mentioned a moment ago. But we did look at the therapist's allegiance, and it was a moderator. Another way of saying that is it explained the level of improvement. And if somebody had an allegiance to individual, the patients improved more in the individual condition. Somebody there would be the principal investigator of the study. Same thing would be true for groups. So, and most of those studies where the allegiance picked up were in the non-identical comparisons. And then in the same year, using the OQ45, we went in and looked at real live differences. So about 70,000 patients who had completed the OQ45, and we compared the outcomes, the improvement in individual, group, and conjoint. And again, the change trajectories were identical, not just in randomized clinical trials, but also in daily practice. So how would you use this information? Going back, to how I started a moment ago, patients sometimes want to go into individual and wait, even if there's a wait list. So we have given a little help to the clinicians. So how to present this evidence when you're trying to recruit a patient into group. So the bold is right from the meta-analysis. So we say something like this: the average person who chooses group treatment ends therapy with improvement matching, and then if we go down to the identical treatments that I just told you about, 49.2% compared to those in individual treatment. That's as close to 50% as you get in a study. And then with the non-identical treatments that I talked about a moment ago, it's still very, very close to 50%. So the effect sizes gives you an idea of differences between two conditions in a meta-analytic comparison. And you can see that these effect sizes, whether you're talking about primary or secondary measures or the identical versus non-identical, about as close to zero as you can get in the study. So we just sort of say, we can put you in a group immediately. The access to the group is much easier than individual. The individual wait list might be 6, 8 weeks, sometimes it's months. And your improvement will be the same. So we use evidence to help recruit members into group that are maybe just a little anxious. And then another set of meta-analysis, again, that Bernard Strauss's lab and I collaborated on across over a decade, was looking at the evidence of group psychotherapy by disorders. So if I'm talking to somebody who might have a major depressive disorder, what's the evidence show for improvement on that? This is a very busy slide. I'm going to break it down into 2 or 3 take-home messages. You can see the disorders off to the side. These are patients now, instead of comparing individual versus group, these are patients who have an eating disorder or a depressive disorder or a generalized anxiety disorder, where the comparison is between those patients who are in an evidence-based group and those patients in the first group versus no treatment, untreated groups. So they may be on a wait list, they may have mental contact. And all of the conditions, all of the disorders showed small to large improvement over waiting. So if I'm trying to talk that same patient who is reluctant, who's got a major depression, we can say that there is large improvement. If you decide to wait instead of going in the group, we look at your improvement compared to that person, the average person who's in an untreated wait list control, there's large improvement. So let's get you in and see if we can help you beat some of these depressive symptoms that you're experiencing. The only disorder that didn't show strong and significant improvement were the schizophrenia population. Then this next group, you can see it's quite long, is a patient sort of saying, well, maybe what I ought to do is medication, or maybe what I ought to do, and they come up with some alternative treatment. You can see treatment as usual, active controls, meds, and whatnot. And here we can show that for the most part, group meets, like medication, group patients meet the improvement for medication, or in some cases with treatment as usual, exceeds improvement. So here what we're doing is using evidence from meta-analyses, whether they be individual versus group comparison, group versus no treatment, or group versus alternative treatments to demonstrate that indeed you're going to improve if you come into group. One of the things that we've learned is just the clinical competencies required to be an effective group leader are different than individual therapy. And we strongly recommend to graduate students who are in training programs that they not only get individual therapy training, but also group therapy training. You can see the therapeutic factors or mechanisms in group are quite different because of the interpersonal, multi-person nature of group. How we select patients. Pre-group preparation is a big piece. It's one of those structural components I mentioned a moment ago. Not going to get to each one of those, but what I will tell you is the American Group Psychotherapy Association had free practice guidelines available to you so that as a potential group leader, you knew a little bit more about the kind of considerations that you would need to pay attention to. So here are some of the references to support this work, and we hope that this gives you a better feel or better introduction to group.